Now let's talk very briefly about abdominal pain in the wild. Now, it's going to be hard to diagnose what the exact cause is, but we're more concerned about what can we do to figure out if this person needs to be evacuated or not. Obviously, the differential diagnosis of abdominal pain is quite extensive, but we really want to know what are the most likely possibilities and which ones do we need to be worried about the most in order to move forward with an evacuation plan. So we ask ourselves, is it dangerous? Some of the most dangerous causes that have a higher prevalence are things listed in the itis group: appendicitis, cholecystitis, pancreatitis, even severe gastroenteritis, even though often not deadly out front, can cause metabolic derangements and severe hypovolemia. Ectopic pregnancy, diabetic ketoacidosis, bowel perforation, though less likely in general. Vascular emergencies, also less likely unless you have a very old elderly patient. Um, and mimics such as ACS. You might have that higher abdominal pain that is actually a cardiac event. An easy first step in the evaluation of abdominal pain is the likelihood. What is this person at risk for? A young, healthy male is unlikely to be having an MI or a AAA or aortic dissection, and they're definitely not going to have an ectopic pregnancy. But if it turns out that that patient is diabetic, then things related to that, such as DKA, will definitely be higher on your differential of things to assess. Also, ask yourself, are others in the group affected? If you're traveling in a group and everybody or multiple people has abdominal cramping with diarrhea, it's likely secondary to a infectious exposure or even a toxin exposure. Thankfully, aside from just educated guessing and likelihood, you have certain tools that you can carry with you to help you diagnose these things, or at least evaluate and rule things out. So a pregnancy test is something very light, easy to carry in your medical kit. Rule out ectopic pregnancy quickly. A point of care glucose. They actually make urine glucose sticks that you can have the patient urinate onto, and they can give you a rough estimate of the glucose in the serum. Now, it's not a slam dunk, obviously, but if it seems to be in the normal range, that might help you rule out a severe DKA. Or if you have a patient that is an insulin-dependent diabetic or even a non-insulin-dependent diabetic, hopefully they carry their own glucose testing machine. Another neat yet expensive tool would be a portable ultrasound. They now make ultrasounds that can adapt to iPhones with a special app, and with this you could potentially look at the gallbladder, the aorta, the appendix, and sort of give yourself an idea of where that patient is at on the likelihood of a severe or deadly pathology being present. During the assessment of abdominal pain, it's easy to use the OPQ-RST mnemonic to help you remember how to evaluate the pain and what questions to ask. Ultimately, at the end of the day, we want to know when we need to be evacuating these patients. If you have a patient who you have a very high suspicion of some serious pathology going on, arrange for evacuation. Or if they appear to be unstable, arrange for evacuation. Thankfully, the National Outdoor Leadership School has put together a guideline, a rough protocol that we can use to help guide us in our evaluation and plan for evacuation of potentially dangerous abdominal pain patients. Now notice that they have a separate column of gastroenteritis compared to just generalized abdominal pain, and that's because acute gastroenteritis is such a common occurrence in the field and most often resolves on its own with minimal medical intervention. Looking at that portion, you'll see that if you have persistent or worsening abdominal pain over 24 hours with spiking fevers or bloody diarrhea or dehydration, you should plan for evacuation. Or if you're unable to tolerate any oral fluids for more than 48 hours, especially if you're having diarrhea and vomiting concurrently, plan for evacuation. If you have just abdominal pain and you're not really concerned about a gastroenteritis, you should really only let that abdominal pain last 12 hours before planning to evacuate, especially if that pain is localized with any signs of peritoneal activity, such as movement with pain or pain when you strike the bottom of the foot, or if they have things like a McBurney's point focal tenderness or a severe Murphy's sign on examination. Other things to consider are the obvious signs of shock or if the severity of the disease is pretty high. And that would go under the classification we mentioned earlier of a unstable patient. One thing to consider in this is that this is not a hard and fast guideline or set of rules, but rather a recipe. And like any good chef, you must be willing to alter the recipe to your specific situation. So it's no surprise that the decision to evacuate can be a difficult one, especially as a first responder or a provider in the field. You never really want to pull someone out or initiate a prolonged evacuation without a good cause. But it's best to err on the side of caution. Use your judgment along with your medical knowledge, whatever potential tools you have, and those guidelines outlined by the NOLS, and you'll find yourself spending less time thinking about it and more time acting.